Everyone deserves to have an endocrinologist fully understand all of the amazing metabolic processes that our bodies are performing. I'm Dr. Lindsey VanDyke, and this is the Endo Days. Welcome to State of the Heart in America, a 4-part series exploring the scope of heart disease in this country and how we can treat it. My name is Dr. Lindsey VanDyke, and I practice in the specialty of diabetes, endocrinology, and metabolism near Dallas, where a large portion of what I do every day is heart attack prevention. I would like to introduce my colleague and friend, Dr. John Osborne, who has more than 2 decades' experience in treating heart disease. Thank you for being here today.
I'm absolutely delighted and honored.
Let's briefly recap your training and qualifications for everybody. You graduated from Jefferson Medical College in Philadelphia, but then went on to earn a second doctorate, a PhD from Harvard Medical School, no big deal, and complete a residency in internal medicine before then completing a fellowship in cardiovascular diseases. That didn't take long at all, did it?
Time flies when you're having fun.
So through all of this, you became an expert in cholesterol, publishing data on atherosclerosis, the biology of our vascular system, and molecular genetics. You are board certified in both internal medicine and cardiovascular disease, and now you practice cardiology here in the Dallas Metroplex. And heart disease keeps you pretty busy. Why is that?
So heart disease is the condition that only 40% of us will die from.
Only 40%.
In about half of men and 2/3 of women, the first symptom of heart disease, that's strokes and heart attacks together, is the first symptom is you die. So that's why this is such a vital problem, to be able to really detect early and prevent. And we have an incredible array of tools to detect this condition early, prevent heart disease from taking your life or shortening it or making your life miserable.
The prevalence in the United States is getting worse along with the increase in obesity and diabetes. Is that right?
It is, actually. For the last 20 years, we've reduced cardiovascular mortality, stroke and heart attack mortality, by roughly 30%. Unfortunately, if you look at the most recent data, that curve of reduction year over year is actually beginning to go back up, and it's felt most of that is due to the epidemic that we have of diabetes.
So one of the things I was taught in my fellowship is that heart disease kills more people than all of the cancers. Is that fair?
That's true, and unfortunately I have to say, not only does heart disease, and I'll include stroke and heart attacks together, kill more people with cancer, but strokes and heart attacks together kill more people than the next 7 causes of death, including cancer.
Oh, I did not know that. Okay, so you said that often the first symptom is death. So tell us about how that happens.
So in general, again, we're talking about deaths from strokes and heart attacks. Obviously, you can have slurred speech, not being able to move an arm or a leg, drooling, facial asymmetry, those kind of classical symptoms of a stroke. But again, sometimes the first symptom of a stroke can actually be a fatal event, a fatal stroke. Correspondingly, in, again, about half of men, 2/3 of women, the first symptom of heart disease, the first time you know you have it, is when you have a fatal heart attack. There's a plaque rupture. In other words, within the vessel, there blood clot forms because of buildup of plaque. This blood clot forms. This blood clot occurs rapidly over seconds to minutes, forms a clot, blocks off the blood flow to the heart muscle, and that then secondarily causes electrical instability of the heart, and you then develop lethal heart rhythms. And just to give you an idea how lethal and bad these heart rhythms are, if you go into ventricular fibrillation, where the heart is completely irregular in its beating, it's no longer able to produce blood flow anymore, the rate of mortality is 10% per minute.
10% per minute. So in an average day, what percentage of our population are dying from this event?
Right, so about 1,200 people a day.
Wow.
Or about one every, if you look at heart attacks, every 60 seconds. If you throw in heart attacks and strokes, it's about one every 38 seconds.
So for your average person who notices they're having a heart attack at home, where is the death occurring? Is it at home? Is it in the hospital right when they get there? Is it next year when they have heart failure? What happens?
Yeah, most of these deaths are occurring out of the hospital and at home or at work. The most common place to have resuscitated cardiac arrest, that is, you collapse, you are resuscitated with CPR, and we use these devices called AEDs, or automatic external defibrillators, are actually in casinos.
Oh, really? Noted. So are these trends just here in the United States, or is this across the globe?
This is a global problem. In fact, what we now call non-communicable diseases. So it used to be, in general, we human beings would die of tuberculosis, cholera, malaria, all of those conditions. But what happens now, as the world is becoming westernized increasingly, both as far as work styles, our intake, and our diet, the major cause of death now in the world is non-communicable diseases, which are basically smoking, heart attacks, heart disease.
So in a global setting, how does the United States compare? Are we better, worse, the same than all these other countries?
I think we're better in as much as we've identified these risk factors. We've been working with them, working to develop treatments for them. I think globally the problem is that they're a little bit behind the eight ball. So we're seeing huge increases in India, in China, and Southeast Asia of heart attacks and strokes and cardiovascular disease, and huge increases worldwide in diabetes. And wherever there's diabetes, there will be heart disease.
What about these so-called blue zones where people live longer and are healthier?
Yeah, so we've also been very interested not only where the fire is, but also where the fire isn't. So we've looked at places where they have lifespans that are much longer than average, in the Mediterranean and Crete and those places. And obviously we want to see what are they doing right. And we find that they stay active. Therefore, they tend to be not overweight. That's where we have the development of this idea of the Mediterranean diet.
Okay, so we care about heart disease because it tries to kill just about everybody. And we all know someone who has had a heart attack or had a stent put in or has had a bypass surgery. So can we talk about the origins of heart disease? Is it really just after we turn 50 and eat fat?
So that's the fascinating thing about heart disease. Historically, we've sort of waited until it happens. And then of those survivors, and that's kind of typically where the cardiologist, people like me, would come involved, then we would say, oh, geez, you had this event, you survived it, of course, and then you get stents and balloons and bypass surgery or go to a nursing home after your stroke and those things. But in reality, cardiovascular disease and stroke and plaque, the underlying thing that causes this problem, it is many ways sort of analogous to the polyps that cause colon cancer, such that the plaques start decades before we ever have symptoms. They slowly progress in a silent way. There's no symptoms, no chest pain, no stroke symptoms, etc. They progress generally over decades, and it's only at the very end of this process that we begin to have symptoms. And in fact, what's fascinating is, particularly in some people that are predisposed to this, who have cholesterol problems, that they can start developing plaque almost prenatally. So this is a condition that really arches way back, much earlier than we ever thought about it. In which case, that means that there's certainly ample opportunity to diagnose this early, and also screen for things that contribute to heart disease early, long before we have our stroke, heart attack, balloon stents, or bypass surgery.
And how do we make those plaques to begin with? It's an inflammatory process, right?
Absolutely. So the way I see it, and the way I explain to my patients, there's kind of two major components. One is cholesterol, and it takes both of these things. But one is cholesterol. Cholesterol is really the stuff that ends up in our blood vessels. That's the stuff that gets into our blood vessels, causes the plaque builds up. But in combination with that is inflammation. So this is, I like to liken it as having sticky vessels, or as I like to say, Velcro versus Teflon, right? We do not want Teflon, or we do not want Velcro in our blood vessels. We want Teflon. And the more the vessels are like Velcro, the more likely the cholesterol is going to stick and build up and cause these plaques that ultimately translate to symptoms.
So what causes it to be sticky?
The big things, now again, they're genetic influences. Age is another factor. What we can fix, I would say the big three things are, in general, tobacco use, high blood pressure, and diabetes. And then associated with all those things are being overweight. Some even link obesity and diabetes together and call it diabesity. All of those things conspire against our blood vessels, contributing to a pro-inflammatory state that ultimately is what fans the fire of plaque, which then is ultimately gets us in trouble with our heart disease.
So let's switch up just a little bit. You currently practice non-interventional cardiology, and that means that you aren't the guy in the middle of the night putting in the stents or managing somebody's current heart attack while it's happening, but you have referred to yourself as an interventional lipidologist. So what does that mean?
It's sort of a joke to say my intervention is not stents or balloons or surgery or those kinds of things. It's really identifying people at risk early and then fixing those things with diet, exercise, perhaps medication, focusing on the cholesterol side and, of course, inflammation as well, in order to actually treat the underlying condition.
So when you look at all these different types of cholesterols, and there's all kinds of data out there, HDL is the good cholesterol, it's the pipe cleaner, LDL is the bad cholesterol, and so on, where's the money at when you're trying to prevent heart attacks?
There's a lot. Cholesterol really is a very complicated arena. There's a lot of different components of it. And as you pointed out, there's the good stuff, as I call it, the HDL. That's the happy, heavenly cholesterol, which you want high. That's how that's the mnemonic I share with my patients to remember that. And then, of course, we have the classical LDL, the low-density lipoprotein, or LDL cholesterol, which is the lousy, lethal cholesterol. But then it gets even more complicated. There's other things that we call non-HDL. There's things called ApoB. There's LP(a). Unfortunately, we have this very unfortunately complicated alphabet and jargon that we use. But the bottom line is that we very much do understand that there are bad cholesterols. And we've got a variety of tools to be able to sort all of those out.
So with the tools we have right now in this country, and many of them being generic, what % of the heart attacks that are out there are preventable?
Yeah, the number that's banted around is probably at least 80%. I would argue it could be upwards of 80%.
It's shocking to me that the huge amounts of data that have been gathered over the decades support that this is a disease that is truly preventable and fully treatable in almost every patient, and yet there are so many people who continue to die or be debilitated by the disease. In Part 2 of State of the Heart, we will examine how we screen for and manage heart disease in the United States and why we don't have such a clear-cut path to success. In the meantime, you can visit www.stateoftheheart.com to learn more.